up earlier than they did when they were younger, and they tend to go to bed earlier. And so some of our diurnal rhythm shifts a little bit, and that could be related to cortisol. Because we're blunting that diurnal rhythm and we're extending that cortisol production period, making it happen earlier in the morning, older people do tend to have higher overall cortisol levels. They're producing more cortisol, and we have higher free cortisol levels because of that increased cortisol production. And this is partially because even though we're producing more cortisol, we're not producing more cortisol binding globulin, and so there's more free cortisol available. So if we look at cortisol production in people who are in their 20s and 30s compared to people who are in their 50s and 60s, the people who are older are going to have higher cortisol levels at baseline. So not only are we producing more cortisol level at baseline, there is also an enhanced response to stress of the HPA axis. And this is both endogenous and exogenous. So if people are in a stressful situation, there's reduced negative feedback from that cortisol because we have higher cortisol levels at baseline. And so the axis is a little bit less sensitive as it is when we're younger. And the same thing is seen in ACTH stimulation testing. So if we're going to do a cosentropin stimulation test in an adult person, the ACTH causes a higher cortisol response and it's prolonged. So if you miss that 30 or 60-minute mark, probably you can measure it a little bit later and you're still going to see that prolonged stress response. So just a little bit different in the physiology between younger people and people as they age. And then we'll go to the middle of the cortex with DHEAS. DHEAS, as we know, is one of the androgens produced by the adrenal gland, and the peak level is right around age 25 in all comers, women and men. And you can see that, we have this very high level at 25, and then we have a slow decline over time. And we get to about that childhood level again by about 80 years, similarly to growth hormone production. As you might suspect, DHEAS is higher in men than it is in women. And the major site of androgen production, as we know, people have, women and men have different gonads. And so the site of androgen production is different in men and women. In men, not only do they make testosterone from the testes, they also make the majority of their DHEAS from the testes. There is some made by the adrenal gland as well. And women, the primary source of DHEAS production does occur in the adrenal glands. So DHEAS decreases over time. Is this something that we should think about replacing? Is this something that we should think about as a potential treatment? And kind of, sort of, in particular groups. So there is data that shows that women who are experiencing some pretty significant vulvovaginal atrophy associated with menopause do benefit from intravaginal suppositories of DHEAS, and this is FDA approved and has some benefit. However, if someone comes to the office and says that they've read about DHEA supplements for mood, for energy, for sex drive, there is no data that shows that this is beneficial. And so right now, we would not recommend that people take these over the counter or from the health food store. All right, while we're on the subject of androgens, which of the following organs produce testosterone? Testes, ovaries, adrenal glands, placenta, everything, or none of the above? Who says testes? Ovaries? There's nodding. Nobody's committing. Adrenal glands? Placenta? All of the above? None of the above. Okay, I did not trick you this time. You're exactly right. So we can make testosterone from any of the following organs, and we will talk about specifically the gonads today because we're not talking about the placenta, and we've already talked about the adrenal glands. And because chivalry is not dead, we are going to talk about the ovaries first. So the ovaries, as opposed to testes, are programmed even before we're born to conk out in midlife. we know that all the follicles in the ovaries are going to have developed in utero. So women who have ovaries have all the follicles, all the eggs that they're ever going to have before they're even born. The peak amount of follicles is right around 7 months of gestation, and that's when we have the most. We have 7 million follicles right around that age period. And then we have this progressive accelerated decline over time. Because we're programmed, the ovaries are programmed to stop functioning before we die, we know that the female reproductive time frame is truncated compared to the male reproductive time frame. And I wanted to point out here, we have about, on average, 37 years of reproductive capability in women. This starts right at the onset of menarche as the very first sign of reproductive potential. And the end of our reproductive time period happens with the last menstrual period. You can't know if you've had your last menstrual period until you stop having them afterwards. And so this is kind of a difficult time period to anticipate, and you sort of know it after the fact. The average age of menopause in the US is about 51 years old, but we can see here that we start to see the signs of decreased ovarian function up to 3 years before the actual event of menopause. And this starts with irregular periods. Maybe they're a little bit different. They're not last as long. There's more time in between each period. Maybe the overall quality changes. And so then we have menopause and the ovaries stop. There is a difference in how estrogen is produced by the ovary or by the body in premenopause and postmenopause states. So before menopause, our estrogen is produced by increased ovarian aromatase function. So we produce estradiol from ovarian aromatase. After menopause, we're making more estrone and less estradiol. And this is from the conversion not of testosterone to estradiol, but from androstenedione to estrone. And so this is potentially one of the explanations for why, even though women are still making an estrogen type of hormone, they have different symptoms after menopause than they would before menopause. Obesity is associated with both elevated testosterone and estradiol levels. And so there is some thought that women who have been diagnosed with overweight or obesity tend to have blunted postmenopausal symptoms because of these additional hormone levels. But signs and symptoms of menopause can be pretty devastating for women because of that decreased estradiol production. And they can include vasomotor symptoms, or the traditional hot flashes that women talk about. The genitourinary syndrome of menopause, which we talked a little bit about, can be alleviated or improved with DHEAS suppositories. Women will notice mood and sleep changes. We experience bone loss, which we'll talk about a little bit more, and then an increased cardiovascular risk as well. So this is not a benign condition, and menopause is something that we need to be aware of in our patients as they get closer to that age range. So aging does affect spermatogenesis and steroidogenesis in testicles, kind of. There's an association. So the effects in the observational studies that we have suggest that this decrease in testicular function is not related to aging, but more related to the comorbidities of aging rather than just aging itself. And this is supported by the fact that men who have the least amount of additional medical diagnoses tend to have normal testosterone levels throughout the lifespan. They also have normal sperm production throughout the lifespan. So it seems to be more correlated with lower overall health as opposed to aging. Now, as men get older, there is a very slightly increased risk in abnormalities of sperm. And this has been shown to be associated with some autosomal dominant conditions like achondroplasia, and then a variety of symptoms, including Alpert-Noonan-Costello syndrome. There has been a slight absolute increased risk for several genetic mutations, some chromosomal defects and epigenetic changes, but overall, sperm production and testosterone production is preserved throughout the male lifetime. This is a graphical representation of testosterone levels throughout the lifespan, and we can see on the x-axis we have age, and then the y-axis we have those testosterone levels. You can see that testosterone levels really peak right around the end of puberty, that early adult time period, but really they maintain pretty normal levels throughout the lifespan. And then this is where those 100-year-old gentlemen come in, as we do have a few data points looking at their testosterone levels. And we can see that at the end here, we have some guys who have testosterone levels. They're 100 years old and they're still within that typical normal range for men. If you wanted to nerd out a little bit, I did convert the nanomoles per liter into nanograms per ml up at the top, so you can kind of see what those normal testosterone levels would be throughout the lifespan. But overall, the testicles are pretty good at maintaining those levels. So thinking about sexual function and reproduction specifically, we know that testosterone is required at the time of puberty for normal sexual function. However, it is not necessary for ongoing sexual function after that time of puberty. And this is demonstrated because we find that people who report signs and symptoms of erectile dysfunction, sexual dysfunction, if we check those morning testosterone levels, they're often within the normal range. And replacing testosterone in those people who report symptoms typically doesn't cause an improvement in symptoms. Now, there is some evidence that shows that decrease in sexual activity is associated with low testosterone levels. And gentlemen who participate in increased amounts of sexual activity have higher testosterone levels. And so is it a chicken or an egg? Does the decrease in testosterone level result in the decreased activity, or are people being less likely to participate in activity and that's causing the low level? It seems to be more of an association than it is an actual cause and effect. All right, moving on to our next endocrine gland. Which of the following does not have a thyroid gland? A dog, a whale shark, a crab, Sophia Vergara, or several of these? Who says a dog? No, Della definitely has a thyroid gland. Who says a whale shark? A crab? Sophia Vergara. Or 8.
I know she had some too.
She did. She had papillary thyroid carcinoma. So the answer, yes, is the crab and Sophia. She has had her thyroid removed. So she started out with the thyroid gland, but she does not currently have one. So we will talk a little bit about how thyroid function changes over the course of the lifespan. So the clearance of thyroid hormone, very similarly to some of the other hormones that we've talked about already, decreases with age. And the half-life of thyroid hormone increases from about a week to about 9 days over time. Because we have more thyroid hormone hanging around for longer in the body, our thyroid hormone production also decreases to compensate for that. If we look at the actual levels of T4 and T3, we start out in young adulthood making about 80 micrograms of T4 every day and about 30 micrograms of T3. And then this decreases over time to 60 micrograms of T4 and 20 micrograms of T3. There's no real difference in free T4 production because we compensate for that decrease in clearance by decreasing thyroid hormone production. So when we look at levels, we shouldn't really see a decrease if the system is working appropriately. However, TSH does rise with age, and I think this is a really important point that we want to focus on. If we look at the normal range, the reference range for TSH, we find that young adults age 20 to 29, about 2.5% of us are going to have a TSH level above the reference range. But if we look at older adults, particularly those 80 years and older, 14.5% are going to have a TSH level above the reference range. So is hypothyroidism more common in older adults? We shall discuss. This is a graph that looks at those TSH levels, and we can see pretty significantly between the ages of 20 and 29, which is the blue circles, 50 and 59, which is the yellow boxes, and then people over the age of 80, that TSH normal range or reference range shifts a little bit. And so we'll talk about what we need to do about that, if there is anything we need to do about it, or whether we should just be aware. So subclinical hypothyroidism. We can argue at another time whether or not this diagnosis actually exists, but it is defined as an elevated TSH with a normal free T4. If we check older people and we find that they do meet the criteria for this diagnosis, if you recheck, 62% of them will have normalized their thyroid function. Looking at the data, the TSH level really determines whether or not we need to be worried about this. If someone is found to have just a mildly elevated TSH, less than 7, but above the reference range, it is not associated with increased risk for heart disease, for cardiovascular mortality, or for stroke. But if we look at people who have a TSH greater than or equal to 10, and I would submit that this is probably more than subclinical hypothyroidism at this time, but we do find that those higher levels of TSH are associated with increased risk for heart disease, cardiovascular mortality, and heart failure. So the degree of TSH elevation really does seem to determine the risk. There is also, in people who have this mild TSH elevation, no evidence that treating with levothyroxine decreases any of these risks. And when we look at the TSH levels in people who are not on treatment, we find that older individuals who have a slightly elevated TSH actually have superior mobility and are a little bit more functional than people who have a TSH in the lower range. So what the recommendation is right now is for mild TSH elevations not to replace, not to treat with levothyroxine in older individuals. Just watch it. But let's shift gears a little bit to subclinical hyperthyroidism. And this is when people are noted to have a low TSH and a normal free T4. Now, this is more common in older individuals because similarly, as we talked about with the adrenal glands, we have a little bit more autonomous secretion of hormone that's not as closely regulated. So the adrenal glands are more likely to make aldosterone independently of renin stimulation, and the thyroid is more likely to make autonomous thyroid hormone without that lack of TSH. Subclinical hyperthyroidism is associated with some pretty significant risks, including atrial fibrillation and increased risk of hip fracture related to osteoporosis, dementia, and coronary heart disease. So it is recommended to treat a low TSH in older individuals. The treatment is going to really depend on the patient's situation. Is this a very functional older adult? Maybe they have a nodule that's found to be autonomous on one side. Maybe a partial thyroidectomy would be a good option. Or is this an older person who lives in a nursing home? They're not very functional. Maybe thinking about radioactive iodine or anti-thyroid medication would be more reasonable. So we talked a little bit about the risk of fracture from hyperthyroidism. We know that older individuals are at higher risk for fracture for other reasons as well. But we'll start with the kids. So bone density is very much dependent on how old we are. And we know that during that early adolescence, young adult time period, that's really the most important time for bone accrual. Looking at this chart here, we see that our peak bone mass we reach right in our early 20s, and we're able to maintain that bone mass until we get to be about 50, 60 years old. After menopause, women demonstrate a pretty significant and progressive bone loss, and this is thought to be related to that decrease in estradiol production by the ovaries, with that switch from testosterone to estradiol to androstenedione to estrone. And when we look at the graph, we can see that at all ages, women have lower bone density levels than men, but women have that much more steep decline right around the menopausal time period. And that's thought to explain why women are typically at higher risk for osteoporosis compared to men. So osteoporosis in adults is defined as a T-score of less than or equal to negative 2.5 at either the spine or the femoral neck. And the prevalence of osteoporosis in the general population is dependent on the sex of the person and the age of the person. For women aged 50 to 59, the prevalence of osteoporosis is just under 7%. And for people who are older, people who are 70 to 79, it increases significantly to just over a third of the population. For men, looking at that same age group, their risk for osteoporosis, their prevalence is only 5%, but they do get higher incidence of osteoporosis as they age. And in those who are older than 80, it's about 10.9%. So pretty common in people as we age, and we know that bone density is going to decrease over time. If we widen the definition a little bit, and instead of looking specifically for osteoporosis, we're looking for low bone density, 50% of adults over the age of 70 are going to be meeting criteria for low bone density. So something that I think it's important to talk about with our younger patients so we can really encourage them to participate in activities that are going to hopefully prolong their bone density and decrease their risk for osteoporosis as they age. So chronic bone loss from osteoporosis is caused by a couple of different things. But when we have this bone loss, we find that the bone microarchitecture is disrupted. So the bones are not put together the way that they were before. And because of this, the bone strength is impaired. And this is what predisposes people with osteoporosis to fracture. As we talked about, fracture risk increases with age, and people who have osteoporosis, 50% of women are going to have a fragility fracture throughout their lifetime, and 20% of men who have been diagnosed with osteoporosis will have an osteoporosis-related fracture. I think this graph is pretty significant too, looking at the risk of fractures over the age range. We can see that the group closest to me is 60 to 69 in age, the middle group is 70 to 79 in age, and then the far group is over 80. And all fractures increase over time. People who are in that 60 to 69 age group, about a 6.5% risk of all fractures, and only 2% that they're going to have an osteoporosis-related fracture. But when we get to the older group, those who are 80 years old and older, 30% of them are going to have a broken bone, regardless of what type of fracture it is. But the risk for osteoporosis-related fracture is about 2/3 of the total fractures. So not only does fracture risk increase, but significant osteoporosis-related fractures, which we know are associated with increased morbidity and mortality, also are increasing in that age group. So we talked about risk factors for fracture, and certainly advanced age, low bone density is a risk factor, and if someone has been falling a lot or has a history of fracture, that is a significant increase as well. One thing that I wanted to point out here in this graph is that the age of a person is going to have a little bit of an influence on their bone density. So older women who have the same T-score as younger women do not have the same bones at baseline. So older women who have a T-score of negative 2.5 are much more likely to fracture than younger women who have a T-score of negative 2.5. So it's not just age, but there are also some other components to bone density that still need to be identified, still need to be delineated, so we can see, why is the risk so different at different age groups? Why are older women more likely to fracture at that same bone density level compared to younger women? And I don't think we have the full answer yet. So screening recommendations. We talked about the increased risk for low bone density. Right now, what the U.S. Task Force recommends is that for women who are 65 and older, we do bone density screening with DEXA scan, and we do the same thing, but we start at over 70 or older for men. So keeping this in the back of our minds as we see those patients who are advancing in age. All right, so we're going to talk about sodium in water. Which of the following has the most sodium per serving? a great sports drink, brand unnamed, nacho cheese tortilla chips, New York cheesecake, or movie theater plain popcorn with no butter? Who says the grape drink? Nobody. How about the chips? Okay, got some votes for chips. How about the cheesecake? Got some cheesecake and the popcorn. I'm kind of split. So the cheesecake wins by 4 milligrams. So New York style cheesecake has 744 milligrams of sodium per serving. So if you're gonna do it, maybe drink a lot of water with your cheesecake. So we'll talk about sodium and water balance and how this changes throughout the lifespan. So our thirst response changes over time. And similarly, we've kind of seen this trend, right? Is that our response to things gets a little bit blunted over time. So younger people tend to have a stronger, more robust response to thirst, or a thirst response compared to adults. This is thought to be due to some decreased activity of the pathways in the brain that transmit that osmotic sensory input to our thirst receptors. So we just become a little bit less sensitive when we actually should be thirsty. There's also some thought that older adults have a higher osmotic set point, and so we're just a little bit more comfortable with higher osmolality when we're older compared to when we're younger. And there is some evidence that we have a decreased baroreceptor response to volume expansion. So again, just less sensitive. I put this study up here because it shows the changes in both fluid intake and sodium level in groups of younger and older adults after they drank some water. The older adults are the purple and the younger adults are the yellow, and we can see that they started before they started doing the blood, and they gave the people as much water as they wanted to drink in response to thirst. And we found that the younger group drank a whole lot more water and had some more dynamic changes in their sodium levels compared to the older group. And so this really demonstrates the differences in thirst response and sodium levels in the age groups. So we have a couple other reasons why we may have differences in sodium and water metabolism as we age. And one thing that we know is that kidney function declines as we age. Our glomerular filtration rate decreases over time, and this results in an inability to maximally concentrate the urine. And so we're just spilling more water as an older adult compared to when we were a younger adult. Because we're spilling more water, we can't maximally concentrate the urine. That does cause us to be at slightly higher risk for things associated with not being able to hold on to water effectively, things like hyperosmolality, hypovolemia, and hypernatremia. However, not only can we just not maximally concentrate our urine, we also can excrete water as well as we used to either. And so this is kind of a catch-22. We can't concentrate, but we can't fully excrete the extra water that we might have. And so this also increases risk for hypervolemic conditions like heart failure, cirrhosis, hyponatremia, and makes us need to be really careful with older adults when we're thinking about rehydration, because the more, if you give the same amount of fluid, they're not going to be able to get rid of it as efficiently as if they were younger and had more efficient kidneys. So ADP secretion is maintained during the aging process, and so this is not thought to be related to AVP release or an increase or a decrease, and it actually may be enhanced in older adults. We also know that AVP is not adequately suppressed by fluid intake, and so we have to be really careful, again, with rehydration, because these individuals who are older might be more likely to hold on to fluid compared to those who are younger. So we'll talk about hypernatremia first. And if we look at people who are in long-term care settings, we find that almost 9% of them are found to have a diagnosis consistent with hypernatremia. It increases significantly after someone is admitted to a nursing home to up to 30% of nursing home residents. And it increases even higher in older individuals who were admitted to the hospital. Between 60 to 80% of hospitalized older adults meet criteria for hypernatremia. So normally, if we're walking around, living at home, doing our own thing, and our sodium rises, our pituitary gland compensates by increasing the production of ABP. This causes us to feel thirsty, and this causes us to drink more water. Sodium goes up, we drink more water, sodium goes back down. But if you're in a place where you're not able to do that, this typical response is complicated. So if someone's admitted to the hospital, maybe they have this limited thirst response, this decreased response at baseline. So maybe they're not super likely to drink water anyways, but they're in a hospital bed. Maybe they don't want to bother their nurse and ask them to bring them some water. Or maybe they have water, but it's out of reach and they can't get it. Or maybe they're on medications. The reason they were admitted to the hospital, maybe heart failure, and they're on diuretics, and so they're losing more water than normal. Or maybe they're NPO for a procedure, or maybe they were admitted for altered mental status and they're not able to communicate the fact that they're thirsty. And so all of these factors are thought to be contributing to that increased risk for hypernatremia in older adults. And this is a big deal because the all-cause mortality for people over the age of 60 with hypernatremia is 42%. 42%. All-cause mortality. And this is 7 times higher than people who do not have hypernatremia when they're admitted to the hospital. So something we really need to be aware of and keep an eye out for. And if we see a sodium level that's climbing in our patients who are admitted, make sure that we address that in addition to the reason that we've been consulted. So we'll shift gears a little bit and we'll talk about hyponatremia, and we'll start with pediatrics. And depending on what study you look at, between 1 to 30% of hospitalized pediatric patients is found to have hyponatremia. And this is thought to be related to a couple of different things. Maybe they're having excess free water retention from those, again, immature pediatric kidneys. Maybe they're losing sodium from renal or GI causes. Or maybe they have syndrome of inappropriate antidiuresis from other things, maybe stress, maybe medications, maybe pulmonary issues. Or maybe they're on medications that are causing them to hold on to more free water. Or maybe they're drinking more water. In adults, it's also right about 30% of hospitalized patients are found to have hyponatremia, and the causes are pretty similar. About 50% is this inappropriate production of AVP, but also low solute intake. We've heard about the classic tea and toast diet where people just don't eat a lot of sodium containing foods when they're older. Maybe they're not hungry or they don't have the capability to prepare food at home. But medications in adults are a big factor towards hyponatremia. Antipsychotics, antidepressants, antiepileptics, and diuretics, all really common in older adults who are hospitalized. And I've separated the thiazides specifically because they have a really high incidence of hyponatremia, almost 14%. But it is not because of an increased production of ADH inappropriately. It is actually an appropriate production of AVP because the solute depletion that occurs specifically for thiazide diuretics in the area of the kidneys in which they work causes hypovolemia in the tubules, which stimulates the baroreceptors. And so AVP is released appropriately in this group. Regardless, hyponatremia is the end result and needs to be monitored for, especially on patients who are on some of these high-risk medications. And then this is also important, like we mentioned with hypernatremia, the all-cause mortality for hypernatremia was 42%. Hyponatremia is also associated with an increased risk for some pretty significant things in hospitalized patients, including neurocognitive defects, increased risk for falling, which can result in fractures, an increased risk for repeat hospitalization, need for long-term care, and then I've put the specific odds ratios for fractures and osteoporosis. And the mortality rate for hyponatremia in a hospitalized adult is 60%. So again, a pretty significant thing to watch out for and to keep in mind when we're prescribing medications for our patients. Okay, so we've talked about some glands today. Which is your favorite? Who says thyroid gland? Pituitary gland? Pancreas? Oh, okay, we got some pancreas. Gonads. Nobody's voting for the gonads. Ovaries, ovaries. Who has a different favorite gland? And who likes all of the glands? You guys, I love this. So you actually have all just become MedPeds endocrinologists, because similarly, I cannot choose between adults and kids, and you cannot choose between the glands. So welcome to my club. So during our time together, hopefully I've been able to express the fact that the endocrine system really is dynamic, and there's some pretty significant hormone changes that occur from birth to death. I do have to point out that a lot of the data that I presented today, a lot of the research we have is observational, and the studies that we have, a lot of them are uncontrolled. They're not randomized clinical trials, and so we don't have a lot of data to support the additional changes in the endocrine system. But I think that begs the point that there is some more research that's needed. Thinking back to the global population, we're going to have 1.5 billion older adults by the year 2050. We need to know this information so we can accurately make plans and help to care for them. We also know that there's significant clinical outcomes associated with endocrine dysfunction during aging, and a lot of these are associated with an increased mortality risk. And so it behooves us to be able to educate ourselves so we can really educate our patients about this. And understanding those age-related changes in the various endocrine organs, feedback loops, the hypothalamic, pituitary, and organ loops, I think really helps to enhance our knowledge as providers, but also really gives us that information and empowers us to be able to care for our patients, no matter how old they are and in what capacity we're caring for them. So thank you so much for your time today, for your attention, and I would love to have a conversation, take any questions, chat about anything that we didn't cover.
There's a lot of talk about healthy aging. And is there any such thing in terms of all these changes that you said as to whether something is more normal than others?
Yeah, so the question is about healthy aging and whether any of these endocrine changes are indicative of healthy aging or dysfunction. And I think what we know is one of the benefits of having observational studies is that they're not interventional. And so we're looking at all comers, all adults, and looking at what happens with thyroid hormone levels and cortisol levels and aldosterone throughout the age or throughout the lifespan. I think it would be really interesting to break it down like they did with the testosterone and see, are these changes prevalent in only people who don't have a lot of additional health comorbidities, or is there a difference between the healthier older adults without a lot of medical conditions versus those who are not thought to be healthy? I think that would be really interesting to look at.
Great overview, thank you. So one observation that was the testosterone levels with aging. So one thing that happens is their free goes down and the total, that the sex hormone binding globulins go up with aging. So the total testosterone looks good or almost, not as low as you would expect. But the free or the bioavailable gets lower. I think that's one of the things that happens normally if the BMI is normal and the BMI high, then we see patients who want to have androgen replacement, which we know is more functional, and just like you pointed out, and many times the replacement doesn't help with it.
Yeah,
it's something I always like to stress.
Yeah, I think that's a really good point. So Dr. Krishnasamy mentioned that the total testosterone is very much dependent on sex hormone binding globulin. And as men age, they tend to produce more sex hormone binding globulin. So the total testosterone level appears really good. Whereas the free testosterone level does decline over time because of that shift in sex hormone binding globulin. But replacing testosterone, even when you have that lower bioavailability, doesn't seem to improve symptoms. But it is really frustrating, I think, for patients to look at their levels and see, well, my free testosterone level is very low, even though they can be reassured that that total testosterone level is still normal. I think it's a difficult conversation to have.
Now, from travelers, we know that replacing it necessarily doesn't help with bone strength.
Yeah, absolutely. And follow
It makes it worse.
Yeah, replacing testosterone for people who don't need it doesn't help with bone strength. Yeah. I'm gonna take a look in the chat and see if we have anything here. Oh, here we go. Okay. Okay, I don't see any questions in the chat. Anything?
So one of the things I which came as a surprise because everybody was trying to think that ITSH means higher. And that was the, I think, the non-engineering study that they had done. Their conclusion was a bit more, they postulated that there is resistance to that hormone, which is why the TSH goes up. But that, I don't know, I mean, I haven't seen any subsequent follow-up to see whether they've been able to establish that.
Yeah, so the comment was that in the non-engineering study, there was some concern that the TSH goes up because of resistance to thyroid hormone and whether that's associated with increased health risks. And I mean, I don't think we know.
Their theory was that that was a good thing. That was why
Yeah.
we were having, the people who were living in their 90s were having the higher TSH, so that must be good.
Yeah, I mean, and that's kind of supported by the observational data where we see that shift in TSH for 14% of older adults have a TSH level above the reference range, and they seem to be healthier and have improved functional capacity and decreased mortality. So I think I mean, we don't know why, but the observational data supports that.
There was a speculation in both directions that, the pulse generator for TRH is supposed to be slower, just like the LH pulses over time. But, so actually they had a robust pulse generator and TSH higher, that it's more cardio effective. Among all this, when they had that anti-aging endocrine sort of Coca-Cola and August, very nice review last year. My hope was they would give us some insight into cognitive decline, which is the biggest challenge. Everything else we can sort of tweak and help, bone health and all that. Cognitive decline is the biggest challenge.
Yeah.
The elder care is sort of evolving fast. And
yeah, I think cognitive, I mean, there's a lot of questions, in what's happening in the news right now too, is are older people more likely to have cognitive decline? And if so, should we think about that when we're interacting with professionals in leadership roles, and what sort of, what sort of effect does it have? And I think we don't know. We don't know if everybody who ages is going to have that consistent cognitive decline, or whether it's associated with other factors. Because, you're exactly right. There are people who are advanced in age who are really sharp, and there are other people who aren't. So there's a lot of really interesting aging research that I think needs to be done, because our population is aging and we don't know. It's a whole new entity. Yeah. Thank you so much, everyone.